Hello everyone, welcome to Dental XP. I'm Dr. Muqaddas, and once again I'm so grateful to be with you all at the world's biggest online dental educational website. And my special thanks as always to my dear friends Maurice, Henry, Eddie, Tyler, David for their dedication to continuing education. Today I want to demonstrate to you a immediate implant placement and how to provisionalize the case, how to manage the gap, what is the best thing possible, what we know, and where are we today. This is the 58-year-old woman came to us with the crown being removed and caries underneath. There is no possibilities to save this tooth for aesthetic reasons, so we decided to extract the tooth and replace it immediately with dental implant. What is very important to know is that what type of socket we are working on. Is it type 1 socket? Is it type 2 socket or type 3 socket? Well, actually here we are facing a type 1 socket. The buccal plate is present. We have good soft tissue, so we're going to place the dental implant simultaneously. What is very important in extracting the tooth is that we should only do rotational movement and extraction. No buccolingual movement. Why? Because we do not want to put any harm to the very thin buccal plate. We want to save it. It's very important for us. And as the sentence I learned from my dear mentor Dennis Tarnow, no buccal bone, no implant, if you're talking about predictability. Then again, clinically, we're going to evaluate the place of the buccal plate. We know that all teeth, exactly like implants, have biologic width. So the level of the crest of the bone here in this case also is about 2 to 3 millimeters below the margin of the soft tissue. So it's very important for us when we want to drill the implant to know where is exactly the level of the crest of the bone. And according to that, we're going to exactly place the platform of the dental implant flush with the bone or about 1 to 2 millimeters apically according to the buccopalatal position of our dental implant. We're going to place the dental implant exactly in the center or to the palatal. When we come to the palatal, then it's more possible for us to place the dental implant flush with the bone. But if we are placing the dental implant exactly in the center of the socket, then we should place the dental implant also a little bit deeper, about 1 to 2 millimeters below the crest of the bone. So what is also the next point very important is that we're not going to drill the case exactly in the place of the socket. We're going to provide a new site for placement of the dental implant. What should be the position? As you can see in the slide, it's almost in the cingulum position of the central incisor, and we have the guide like the adjacent tooth. We're going to check the placement of the drill. We're going to go to the final preparation, and then we're going to place our dental implant. As I mentioned earlier, it's very important to have a distance from the buccal plate. It's very, very critical, because if we place the dental implant in contact with the buccal plate, we're going to lose that bone. So it's very important to have that distance. After placing the dental implant, as you can see, I've put the path pin there. You can see the path, you can see the relation to the adjacent jaw, you can check the relation to the adjacent teeth. Now you can see we have a gap here. What should do with the gap? Well, at first, most of us thought that we should augment the gap to prevent the soft tissue to migrate down there. In a famous article by Dennis Tarnow and Steve Chu, they did a human histologic study, and they showed that when they put nothing in the gap, nothing, and they removed the dental implant and had a histology evaluation, they showed that there is bone formation up to the first thread. And why? Because here we have clot, and clot is dead, so the tissue cannot migrate to a dead piece. So no worry about it. But should we augment the gap again or not? Yes, we should. Why? Not for prevention the soft tissue to migrate down there, but to prevent the collapse of this soft tissue and buccal plate to the toward the implant. We want to save this contour, so we're going to augment the gap to the level of the soft tissue margin, not to the level of the crest of the bone. So it's very, very critical. Now we've placed the dental implant, we've checked the position, everything seems to be great. Now we're going to provisionalize the case with these PEEK abutments, temporary abutments. They can be stainless steel, they can be polyether ketone. Well, PEEK abutments is easier to work, easier to trim, easier to shape. We have different methods for provisionalize the case. First, I'm going to tell you why it's better to provisionalize the case. Because with provisionalization, first, you're going to give your patient the aesthetic. So patient come with the tooth and go with the tooth, or come without tooth but go with the tooth. Second, it's very important to save the shape of the tissue and save the height of the papilla, because when we extract the tooth and if we don't provisionalize the case, that height of the papilla will collapse, and it's much easier to save the height of it comparing to about 3 months later, 4 months later, come back and build that up again with provisional restoration. We have different methods for provisionalization according to compendium, the one by Steve Chu and Dennis Tarnow. We can use shells. We can also use flowable composites, as it was my choice in this case. We can use fast cure acryls like the one by GC, and we have so many choices. So in this case, first I fix my temporary abutments on my implant, then I fill the voids around it between the soft tissue and temporary abutment with flowable composites to have the primary form of my socket, buccopalatally and mesiodistally, and then we're going to cure it, and we're going to remove the provisional, and we're going to finish our case, finish the shaping of the this central incisal outside the mouth. If the patient firsthand had the central incisor in place, we could have an impression and do these things more faster. But in this case, we try to build a new central with composites, and as you can see, we have voids here. We're going to fill the voids by fixing that temporary abutments on implant analog to have it in our hand and do it more easily. We have beautiful videos on how to provisionalize the case on dentalxp.com by Steve Chu, by Howard Glockman, by Dr. Lemangelo, by Jay Lerner. So for more information, you can go to their webinars also. After finishing our provisional, we're going to augment the gap. Again, I put my path in there to save the insertion of the screws, because I don't want my graft material to go to my dental implant. Then here in this case, I used a synthetic material. It's 70% beta TCP and 30% HA to save the contour of the tissue. I'm going to pack this bone material not only between the buccal plate and dental implant, but also to the level of the soft tissue margin, because when I put my provisional, there may be again some spaces left between the provisional and the soft tissue. So these graft materials can save that void, can fill that voids and prevent the tissue to collapse. Then I'm gonna fix the provisional in place. As you can see, when I finish fixing my provisional, you can see the excess of the material coming out from the sulcus. I'm gonna remove the excess, and the patient can go with this provisional at that time. I'm gonna see my patient every month, and the patient will come back in about 4 to 5 months, and the tissue is totally matured at that time. Hopefully, you can see we were pretty good successful, not going to say 100%, but pretty good successful on saving the contour of the tissue and the level of the papilla comparing to the adjacent teeth. And the case is finished right now, and we can go with the final restoration. At last, on behalf of Dental XP team, I want to invite you all to Dental XP Global Symposium 2016, the 4th Dental XP Symposium, with the great number of speakers. I just put them here: Danny Boozer, Marcus Herzoler, Dennis Tarnow, Mike Picus, so many names in this symposium with so many great workshops. It's opportunity of the year 2016, I think. It's going to be February 4th to 6th, at the Fort Lauderdale, sunny Florida. So for more information, you can go to dentalxp.com, and hope to see you all there. Thank you so much again for joining me today. I'm looking forward to hear your comments and answer your questions. Bye-bye.